replacement or estrogen therapy when we're symptomatic. And to me, that is a travesty for women who have the most symptoms, are the least likely ones to get a conversation about menopause and to get treatment for those symptoms when they have them.
So Sharon, I'm just going to call you Sharon. We're just going to be Sharon and Jane.
Yes.
It's hard to call you Dr. Malone and Dr. Morgan. I have to keep thinking about it. So we'll just be Sharon and Jane.
Yes.
So here is, the concern. All of those trials, clinical trials, right, coming out of the 80s and 90s. I remember when I was a cardiology fellow, trial results of the Women's Initiative, I think, in Britain. And it showed that it, I think, reduced cardiovascular endpoints, but there was an increase in breast cancer. And they called on me in rounds and said, at the time, my name was Middlebrooks or Jimenez. I don't know which name I was using or which husband I was on, but when at the time they called them and said, so, would you, Dr. Middlebrooks, prescribe this medicine or take it yourself if it decreased your cardiovascular risk? And we know that heart disease is the #1 killer of women, but increase your risk of breast cancer. And I remember saying, no, I wouldn't do that. Right. And I think you're right. There was like a whole generation of these trials and these results coming out. So let's talk about that, because they were using different types of progesterone, synthetic versus natural, combination with estrogen, and the results were kind of all over the place, and we were lumping them all together into one thing. And then clinical trials just stopped. Right? We became another group that was never enrolled really in clinical trials, and we got no further information. So let's talk about kind of these hormones and what they mean and why we've been avoiding them and why our doctors are even avoiding them.
Right. And I think it's worth a minute or two to go into the Women's Health Initiative, which is really all of that data, where that data came from, on the fact that it didn't improve outcomes for cardiovascular disease, but it increased the risk of breast cancer. And if you say increase the risk of breast cancer, women will jump off that ship quicker than you can say, Jack Rabbit. But that study, and this is why it's important, that study those reports came out 20 years ago in July. So imagine, people are still operating on data from a study that was reported out 20 years ago, and the patients were enrolled in that study almost 30 years ago. And for those of you who aren't familiar with the Women's Health Initiative, and it's sort of every now and then there's an advantage to being old. And I'm old enough to have practiced before the Women's Health Initiative came out. And you probably remember this, Jane, we were giving hormones to women, almost recommending that they take it, because just as Jane said, the #1 killer of women is not breast cancer, it's cardiovascular disease. And for the data on hormones, and we had over 40 years of just sort of observational data that said that women who took hormones had half the risk of heart disease than women who didn't take hormones. So the thought was, well, if you could cut the risk of heart disease in half and only slightly increase the risk of breast cancer, if you do the cost-benefit analysis of that, you're going to save more women's lives because of the decrease in risk of heart disease than the slight increase in the risk of breast cancer. And that was what started the whole study about the Women's Health Initiative. And of course, they said, well, let's do a study. And this was what started the Women's Health Initiative. It was a randomized, double-blind, controlled study that looked at 27,000 women enrolled all across the country, and they gave them estrogen and progestin or estrogen alone and compared them to the control group to see how they fared. And after the study was supposed to go for 10 years, they stopped it at 5 because they said, oh, there's no benefit. Now, we went into the study thinking that it was going to decrease the risk of heart disease, but there was no improvement in the cardiovascular disease. And that slight risk in breast cancer that we kind of knew was out there was the risk that also stopped the study. Because if you didn't get any benefit, that was the whole reason why we were prescribing it, and you had excess harm, study stopped. headlines went out, and the headlines went out to everyone in the newspaper before even the principal investigators who were doing the study had a chance to review it.
Right.
And here's the problem with that study. If I were going to prescribe hormones to someone, and the way we had been prescribing hormones, you'd give it to someone who's got symptoms, right? Why would you we weren't giving hormones to women for prevention. We were giving it to you because you had hot flashes and night sweats and all of those things. You gave it to women who were going through the menopausal transition at that point. But that's not how the study was constructed. The study allowed women to enter into the group. You could be anywhere from 49 to 79 to be in the study. So the average age of the women entering the Women's Health Initiative study was 63 years old, which is a full 10, 11 years after the time of the natural menopause. Now, it makes sense, and everybody can understand that if you're going to do a prevention study, if you're trying to prevent heart disease, you can't give a medication 12 years after someone has already developed heart disease. Right. You're sort of closing the barn door after the horse is already out. So that was mistake number one in the study. They enrolled women who were too old and who probably already had established heart disease at the time they entered the study. The second big problem with the study is that they didn't look at different doses of medication. They didn't look at different types of progestin, because we have more than one type, but they used a medication that was commonly prescribed at that, Primpro. The drug company who made Primpro provided the drug, so we had no idea to say whether or not one dose was better than another, or one progestin was better than the other. You had one dose of medication, and that was everything in that study. They generalized one dose to all women of all ages. But all of that excess harm really was in women who were much older. When they sort of re-examined the data, and they have several times over, in these 20 years, they found out that when you separated the women who were in the 50 to 59 age group, who were the women who we would normally prescribe hormones to, they didn't see, there is a slight cardiac benefit for those women. And not only that, but the increased risk of breast cancer was nominal. I mean, nominal for women who take. So the take-home message from that is that hormone replacement is not a good idea for someone to take more than 10 years after you've completed menopause, because your prevention benefit goes away. And that slight increase in the risk of breast cancer, if that were the only thing you were looking at in that study, it wouldn't have even been statistically significant. It was just that the benefit got wiped away because you couldn't prove the cardiac benefit. And I hope that makes sense to you, because the timing is important. And now that we've sort of looked at it again, and we've come back and we've looked at different types of progestin. Oh, and here's another important point.
And we definitely want to talk about the different types and what it is that we should be.
Yes. And I'm going to say one thing that did come out of the Women's Health Initiative, though, that I think got completely sort of lost in that interpretation, is that for women, the only women who need to take a progestin or progesterone type medication in addition to your estrogen, and all of the symptom relief comes from your estrogen. So if you got hot flashes, you got mood swings, all of that, the active ingredient really there is the estrogen. You only have to take a progestin or progesterone type medication if you have a uterus, because it protects the lining of the uterus so you don't end up with cancer of the lining of the uterus. That's its only purpose. So they had women who were in the study who had had hysterectomies.
Right.
So if you had a hysterectomy and you don't need to take the progestin. And this was a very important point. The women who took estrogen alone, because they had hysterectomies, their risk of breast cancer was lower. It was 30% lower than the women who took the estrogen and progestin together. So it appears that even sort of looking at this data again and looking at it, the different types of progesterone, and many of you may have heard of bioidentical hormones, and all that means is just that the progestin is the same, chemically the same structure as that you would make if your ovaries were making it.
Yeah.
But
that's a good question, because we've got that question in chat. What are bioidentical hormones? And the other question that I will answer, I see a question is asking, what about estradiol? She's actually talking about estradiol, but she's talking about estrogen. So that's just sort of another name for estrogen. So when she's saying estrogen, you can think estradiol. I see these questions coming up. So, okay, great.
And so that's something that sort of got lost in the translation. And there are also different ways to take estrogen. You can take it orally, or you could use it as a patch, which goes directly, or a transdermal, a gel, or as opposed to a pill. But the point of the matter that I'm really trying to say here is that everybody got painted with the same broad brush. Right. They took those studies and the same sort of results that they got in a 79-year-old, they gave said the same thing happened to a 49-year-old. Right. And that was not. It matters tremendously where you are in that process. We have gotten to a point now where we know that these synthetic progestins, have more of an effect on the breast than the natural or the bioidentical progesterones. And there's another big study that just came out of Great Britain that shows that for women who take estrogen or estradiol and the micronized progesterone or the bioidentical progesterone, no increase in the risk of breast cancer. So, if you had to go back and look at this again and say, the number one reason why women don't want to take hormones is, that worry and concern about breast cancer. But let's talk about some of the other long-term benefits, and particularly when it comes to women of color.
Absolutely. Sharon, I'm going to interrupt you one more time because there's a debate going on in the chat about testosterone, that many people's doctors prescribe them estrogen and progesterone and testosterone. And so how does testosterone play into this?
Testosterone has, there's a lot of evidence that says that testosterone works for women who have libido issues, But here's the problem with testosterone.
Libido meaning that you have a low sex drive, that you've got a low sex drive, you have decreased interest in sex. So the testosterone increases your libido, your interest in sex.
Right, exactly. But here's the problem with testosterone, and we're trying to do FDA-approved, medications, and that is the estradiol and the natural progesterone. There is no FDA-approved formulation of testosterone for women, okay? And since there is no FDA-approved version of it, the other problem with testosterone is that we don't really know. Let me put it this way. That's not true. It has to be monitored. A little bit of testosterone is good. A lot of testosterone is really bad because you're going to end up with acne, facial hair, losing your hair. I mean, there are a lot of things. So you have to be really careful if you add testosterone to the mix. And there are a few women that benefit from testosterone. The overwhelming majority of women do not need it, but please be careful. And this is the thing I would say. If you are getting pellets and people are doing, and bear in mind, bioidentical hormones are not the same thing as compounded hormones. Because compounded hormones are just things that people are going, pharmacists make them up. They're individual batches of things that are formulated, but they are not FDA regulated. You have no idea what's in them. You don't know if they are pure. And so the American College of Obstetricians and Gynecologists recommends against using those compounded hormones because you really have no idea of knowing if what they say is in it and in the right amounts. So be careful on the testosterone. Don't ever let anyone give you a testosterone preparation that they can't take back. Because if someone gives you a pellet in your butt and it's going to last for 6 months, if you have problems with it or complications, too bad. You're just going to have to wait until it wears off.
So that's good, because it looks as if several women say they're on small doses of testosterone, and they feel as if they feel better, and that they're being closely monitored. They don't exactly know their dose, but I'm glad you're saying that it can't be compounded. It can't be something that you can't take back.
But I would say, and that is true of the pellets. But there is a lot of data out there that says testosterone and how would you know? The doses for women are regulated at about 1/10 the dose that you would prescribe for men for testosterone supplementation. So to get an FDA approved formulation, you can get a doctor to prescribe the testosterone for men, because at least that's FDA approved. Right. But the question becomes, how do you titrate that dose? Because it's really hard, because they're metered gels or pumps, and you got to use a little syringe or something to do that. And then if you're going to do that, you have to make sure that you actually follow up with your doctor and get your testosterone levels checked to make sure that you don't go outside the range of what normal women should be. So it's a little bit more complicated. Testosterone is also a regulated medication where you have to have, you have to use the same sort of schedule. It's a Schedule 3, I think, drug where you have to have a DEA number. You can't do it online. You have to have a written prescription by a doctor that says you can have testosterone.
Yeah. And so most women, perimenopausal or menopausal, would either need estrogen alone, is the question, estrogen alone, or a combination of estrogen and progesterone, depending on whether you actually have a uterus, meaning have you had a hysterectomy, or you don't have a uterus. It's generally one of those, and there are different routes via which you can get the estrogen, right? It can be pills or pellets or patches or creams. How does that work?
Yeah, you can. Estrogen you can take as a pill, just the oral pill. You can use it as a patch, that usually the patches are changed once or twice a week, depending upon which patch formulation you have. They're gels, and you can just rub into your skin. And these are FDA approved estrogen preparations that women can use. And the only real limiting factor is is ease of use, because I think that it's important that we can't let the perfect get in the way of the good. Because the patches are great, but some people don't like the patches. There is a convenience factor that it works for some women, it doesn't work for others. Some women prefer to take a pill. So unless there's a particular reason why you should or should not take the pill, it's a matter of cost, convenience, and what you're willing to do and what you can comply with.
And unopposed estrogen, we should not be afraid of unopposed estrogen at a specific dose.
As long as you do not have a uterus, and that's the message that I really want to get to when I say to African American women, we're also far more likely to have had a hysterectomy.
Because of fibroids and all kinds of
That's a whole other conversation about why we have so many hysterectomies. But the reality is that if you've had a hysterectomy, then all of the risks and things that you worry about hormones drop precipitously. I mean, because then if you're taking estrogen alone, you don't have heart, you don't have the breast cancer issue. And even if you take estrogen and natural progesterone, you don't have an increased risk of breast cancer. But let me tell you, and this is something that I think is really important, and particularly as it relates to cardiovascular disease risk. And Jane, you know this, women, there is certainly an increased risk in cardiovascular disease in women who have more belly fat and that sort of visceral fat that is toxic. When you go through menopause,
that's where I gain weight. That's me.
But that's the kind of fat that increases your risk of cardiovascular disease. It increases your risk of type 2 diabetes. And so that weight gain that happens with menopause, and we're all going to gain weight a little bit as we get older. But women who don't take hormones tend to predominantly put that weight in their middle, which is an independent risk factor for developing cardiovascular disease. The other risk factor for cardiovascular disease is disrupted sleep.
Right.
So if you,
I'm just going to interrupt you one more time. Cardiovascular disease, she means like heart disease, heart attacks.
Strokes.
That's what when she says cardiovascular, she's talking about heart attacks and strokes. Okay, go ahead.
That would be, and if the more belly fat you accumulate, the more sleep disturbance and stress you have. These are also things that increase your risk of having heart attack and stroke.
Right.
And so it makes some sense from, when you say that women who are most symptomatic are more at risk for developing heart disease because of the fact that this can go on for 4, 5, 10 years of this disrupted sleep.
Right.
And also an increased risk, that belly fat gives you an increased risk of type 2 diabetes.
Right. Which also increases your heart disease and risk. That's right.
Increases your risk of heart disease. And then it also, so there are a lot of reasons why, when we thought that estrogen decreased risk of cardiovascular disease, that's probably true for those reasons: the disrupted sleep, increased risk in the type 2 diabetes, and that belly fat and inflammation that goes along with it. So, for women who are most at risk, particularly for cardiovascular disease and developing that belly fat that really is toxic, again, other benefits of taking estrogen after menopause.
That's right.
But honestly, I
it's
think
genetic. That's where the women in my family gain it. It's around here.
Yeah, and most women do, after menopause, and and you don't get, when you gain weight, you don't get to decide where it goes, and you hope for the best.
That's right.
But knowing these things, and another misconception is that Black women don't get osteoporosis. Yes, we do.
Yeah, we should say something. That's right, about joint pains and bone pain, and that could be menopause. That really, as I said at the beginning, when you've got a constellation of symptoms, instead of going to 10 doctors, you need to go to one doctor who can pull all 10 of those symptoms together and come up with something. So it may be that you just need hormone replacement therapy.
Right. And we haven't even gotten to the issues, because I think that the strategy ought to be this. If you are symptomatic, and by that, and you are miserable, and you are having all of these symptoms, you can't sleep, stress, palpitations, all of that, why would you not choose something? And again, and we're going to take out of this for the moment the women. There are some women who cannot take hormones. If you have had breast cancer, you cannot take breast. You cannot. If you've had a blood clot or a pulmonary embolus, you cannot take hormones.
Which is a blood clot in your lungs. Any kind of blood clot.
Any kind of blood clot. So let's take those women.
And that would be a stroke. That includes strokes.
And you're looking at healthy women who are symptomatic. Why would you suffer and increase your risk of other long-term heart disease issues too?
Yeah, let's say that again. Why would you suffer?
Would you?
And increase your risk of heart disease. Let's say that again. Why would you suffer and increase your risk of heart disease? And that's what we want to know. You may have to take this information back to your doctors as well.
Yeah, because I think that this is something, particularly as Black women. I mean, the notion of knowing how you feel and what it feels like to feel good and feel normal is lost when you are tired and exhausted and you don't get a good night's sleep and you generally just don't feel well. Pain is a sign that something is wrong. And when you normalize suffering, you don't feel good because you never feel good. It sort of masks all those other things that are signs and warning signs of other things that are more prevalent. So, I think that we have just sort of taken that on the chin and even the notion, the language that we use about menopause, that we just suffer through.
Right.
And I just don't believe in suffering. I mean, I think that if there are reasons that you can choose feeling better and it improves the overall quality of your health, and we haven't even touched on urinary tract infections, which happen even for women who are completely asymptomatic during menopause as far as the hot flashes are concerned, things that you may not associate with menopause because they tend to come up later are things like vaginal dryness, urinary tract infections, urinary frequency, urgency. All of those things tend to come much later. Like you may not have them right away during the menopause, but you may have them when you're 55 or when you're 60. And even if you choose not to do hormone replacement in terms of pills or patches, there is topical estrogen that you can use. You know, there's no reason why women should have painful sex, frequent urinary tract infections, and that sort of vaginal estrogen, either a cream or a pill or a ring that you can just use directly in your vagina, you can use that basically with impunity, and you will get relief, and you can use that for as long as you want to use it, because there are, and I can tell you as being a gynecologist, you know, women will come in and they will just, you know, say, they just stop having sex. It's too painful. It's too, you know, I don't like the, you know, the urinary tract. And then the decreased sensation that happens as a result too. So, you know, there is a whole range of things when we're talking about hormones during the menopausal transition or after. You know, everything is not for everybody, you know. So it depends on what your symptoms are, what your risk profile is, and because it's going to be a better idea for some women than for others. But don't just rule it out because of something that you heard or your doctor. And doctors are a big source of misinformation because they're still giving you information from that study from 20 years ago. Remember, It was a 20-year-old study, and we're still talking about the Women's Health Initiative like it happened yesterday. So if your doctor's telling you that kind of stuff, then you need to say, no.
You need to reach out to Dr. Malone.
Yeah, you need to get some more information.
So we are out of time so fast. I've got a couple of questions that I can answer, but I'm gonna let you answer that I saw in the chat. One is, if you start hormone replacement therapy, can you take it forever? How long can you take it? And the other one is, do you have to have an OBGYN prescribe it, or could you go to your family practitioner, or should you not do that because they don't really know as much as the OBGYN, so don't risk it? So those are kind of the two questions.
Okay, well, let me just say, there are a couple of things here. Only about 20% of OBGYNs feel comfortable prescribing hormones, because so much of what we do in OBGYN is obstetrics related. You know, we're delivering babies and doing stuff, and when women get to be a certain age, you're like, oh, you know, nobody's got time to talk to you about that kind of stuff. So one is, if you can find a doctor who is a certified national menopause practitioner, and that is a certification that comes from the North American Menopause Society.
I did not know there was a certification.
There's a certification. They're hard to find, though, because they may not be everywhere. The company that I work for and that I'm the chief medical officer for is Alloy Women's Health. It allows you to have a workaround. We have information on our website about menopause. You can take a 3-minute questionnaire to find out whether or not you could be a candidate for hormone replacement therapy.
I'm typing that in. Alloy is the name of her company. So look it up, Alloy, because you can actually get the prescriptions through her company. She's telling you how you can go on the website and have a telemedicine consult.
And you can get the medication mailed directly to you. So, and we do hormones, we do vaginal estrogen, and we also do paroxetine, which is a low-dose antidepressant that works for some women who have hot flashes who can't take hormones. But so that's a way to do it. But, you know, finding to be a certified menopause practitioner, you don't have to be an OBGYN. It's just that if I tell you that 20% of OBGYNs know how to treat menopause, well, probably only about 2% of internal medicine or family practitioners.
So that's your answer. Don't go to a family practitioner. You've got to seek a gynecologist with this certification.
Right, but I won't say that, because there are family practitioners who do treat menopause, but just make sure that there's a person who has an interest in treating menopause, you know, and they don't necessarily have to be certified, but if you, chances are, if you're seeing a doctor, and it's not, this is ageism in reverse. If your doctor is 35, she or he does not know how to treat menopause. I can tell you that. You know, we all get a little bit more interested in menopause. The older I get, the more interesting it became as a topic.
Well, I tell you, we have also comments about we don't want this to end. We'd like for there to be a part 2. So I might have you back, Sharon.
You know what? You can have me back anytime. And I think that, but do follow us. Go to myalloy.com.
Yeah,
we have a lot
I'm going to write it on here, myalloy. Okay.
Yeah, we have a lot of content and just educational stuff, just so you can know what the symptoms are about, you know, what the symptoms are of menopause, what the treatment options are. And I think that menopause in particular is a really good area of women's health to be dealt with this way, because it doesn't, you know, it's basically information and deciding. And we trust that women, when you give women information, they can make decisions for themselves. I mean, that's the whole point. If I can tell you what the risks and benefits are, and you think that this is something that you would benefit you, you know, we as physicians are there to provide guardrails. We don't want to give it to anyone for whom it is unsafe.
That's right.
But once we've determined, and that's my job, to develop the protocols to just say who can't have it or who shouldn't have it.
That's right, because everybody can't have it. She gave some exceptions already, but there's a screening process when you go onto myalloy. So this whole telemedicine, so you will be screened and triaged.
And that's the thing about it. And then once you decide, you can get the medication. You know, it's mailed directly to you. And, you know, none of what we give is irreversible. So you're either going to feel results pretty quickly on, or, you know, and you'll know. Right. You know when you're feeling better. It doesn't take a year to figure that out. It takes a month to figure out whether you're feeling better.
Well, I love it. We got to as many questions as we could. You guys, I put myalloy.com in the chat. S. Malone, MD. You can follow her on Instagram and Twitter. You know, I'm at Dr. Jane Morgan, Instagram, Twitter, YouTube, LinkedIn. You can find me all over the place. And maybe Sharon and I'll come back to do a part 2. Send me your questions. I like that there's a lot of interest, and we need to be able to advocate better for ourselves. As Sharon said, maybe only 20% even of OBGYNs understand this, so you've got to be able to advocate for yourself, know what to ask for, and know when to move and get a second opinion about something. Because this information, I quoted Sharon, she says, you know, not only has there been a whole generation of women who've grown up thinking hormones are bad, there's also been a whole generation of doctors. So you know how to find the information and advocate for yourselves, and this is one of the reasons we're doing this today. So I love it. Thank you for coming, Sharon. Thank you, guys.